So, good morning, everyone. My name is Kerry McLaverty, and I have the privilege of calling myself the CEO at Laura Lynn Children's Hospice. It is an absolute delight to be here today, and very fittingly right in the middle of Children's Hospice Week, but to help to chair this, our second session, and to help launch the ECHPI study, which Laura Lynn is absolutely so proud to co-fund along with our colleagues in the Irish Hospice Foundation and the Health Research Board. And I think, as somebody who gets really excited by research, as nerdy as that may sound, I think today is just incredibly exciting. This research is the clearest picture we have ever had in Ireland of how children's palliative care needs translate into service demand across the health system. Laura Lynn is in its 15th year this year, and we have grown considerably over those 15 years, but we've been doing so without really knowing what the real demand for our service is. And so now, on foot of this research, we have a real critical foundation for how we need to grow and develop our services to ensure that families like Orla don't have to travel, huge distances to access palliative care services and supports. So as a service provider, we know, as we've long suspected, that there are more children and families out there that really need us. And so at Laura Lynn, we know that we have a lot more to do. And I know there's a couple of my board members that are sitting in the audience today, and I know that they are committed to deliver upon our current strategy of making sure that we provide equitable and accessible children's hospice care for families all across Ireland, no matter where you live. So with that said, it is my absolute honour to introduce Dr. Joanne Balfe. Joanne is a consultant paediatrician specialising in neurodisability at Children's Health Ireland, and until recently she also worked with us at Laura Lynn. Joanne is the lead knowledge user for this project and co-led the project with Samantha. Joanne is going to present to us on the second set of key findings from the project, which outline hospital activity by children with life-limiting conditions in Ireland. And while initially the main motivator for the project was to develop the prevalence work, and as important as it is, in many ways, the analysis of hospital activity highlights many useful areas for policy and planning for further research. So, Joanne, over to you.
Thank you. Thank you so much, Kerry, and thank you all for coming to allow us to share this these findings with us. I've been on a really long journey to this point, not from home, that's very close, but I've been working with children with complex needs and palliative care needs for almost 20 years now. About 10 years ago, Julie Ling and I did some sums in the back of an envelope in the canteen of Laura Lynn and came up with a figure of 3,840 children with life-limiting conditions. And I was delighted when that was published as a letter in the Irish Medical Journal. So you can imagine how excited I am that we are actually providing high-quality data. I just want to say something really briefly, because people have said it already, but reiterate the value of this APA method. So this research, which has been included Samantha's academic brilliance, her ability to access, assess, and interrogate the data. And I think then I'm happy to say that me and the other parts of the project team, the clinicians, have been able to convert that into meaningful questions that we hope will make a real difference to children, and all the time thinking about the child behind every statistic. So what I'm going to talk to you about very briefly is about hospital use patterns. These are really, I think they're really interesting. I work in hospitals. And this is observational analysis of acute hospital discharges in Ireland between 2009 and 2024. So every time that a child is discharged from hospital, the chart, at the moment a paper chart, goes to a hype office where it's coded. And they collect data on demographics, age, gender, geographical area. They categorize the primary diagnosis, then up to 30 additional diagnoses, procedures that occur within that hospital admission, not things like administration of medications, but IV medications, surgery, interventions from therapists. And then that is graded with clinical complexity, so length of stay, etc. And all of this comes into a HYPE code. So that's what we're examining here. There are limitations. So we've said repeatedly we don't have a unique health identifier in Ireland. And this only talks about hospital level discharges. So we have no data about community use, primary care use, respite, disability services, or hospices. But what we found is, and it's kind of the summary, is that children with life-limiting conditions are less than 1% of the population. But across Ireland, are about 7.6% of total inpatient discharges, 24% of all day case discharges, that's a lot of oncology within that, and 14.3% of all discharges from paediatric units across the country. We have some really interesting data from discharges over time. This looks very similar to Lorna's pictures from the UK. So what we can see from 2009 to 2019 is that the rate of discharge of children without life-limiting conditions fell by about 1% over that, using a 3-year moving average. So this is the top graph is the number of children, the bottom graph is the rate per 10,000, the top graph, the dotted line is the annual figure, and the straight line is the 3-year moving average. And the 3-year moving average of life-limiting children is an increase of 4.3%. So that's 23,000 discharges over 3 years around 2019. And I think this graph highlights very clearly why we examined 2019, because of this huge impact of COVID on health services. And anyone who worked in acute paediatrics at the time will tell you this was the reality. We had no children in our emergency departments. We had a really significant reduction in inpatient admissions, but that reduction was greater in the children with non-life-limiting conditions compared to life-limiting conditions. So they had a 15% reduction in life-limiting conditions and 25% in non-life-limiting conditions. We've also had some changes in age-specific variation over time. This is harder to explain. I think it needs further examination. So there has been, in both the life-limiting and non-life-limiting group, a decrease in that 0 to 5 year group, but an increase in that group. The fourth and fifth, so the top children between 6 and 15 years, over the time period, there has been an increase in the number of discharges in those groups and a marginal decrease in the 16 to 19 years. But this is a real area that we need additional data, because we need to study this through 24-25 and beyond. But I think it's when we start looking at length of stay data that we really see the difference between these two cohorts of children. So people talk about the concept of dichotomization of child health, this idea that within the childhood population in the developed world, that we have two big groups of children. The vast majority of children are really healthy and well. They have infrequent, short contact with healthcare services with minor illnesses from which they recover. And you see this here. So over 80% of children without life-limiting conditions, when they're admitted to hospital, have a length of stay of less than 3 days. And in contrast, you have an small but increasing group of children with life-limiting conditions and complex care needs who are more frequent users of healthcare services and tend to be in hospital for longer. And this is known internationally. So that 44% of children with life-limiting conditions, when they're admitted to hospital, are in hospital for more than 4 days. And you can see that 5% of children with life-limiting conditions, when they're admitted to hospital, are in hospital for more than a month. That is a really, really long time to be in hospital. If you've ever been in hospital, a day is a long time. So a month, particularly when you're considering the life of a child, when you're thinking about Cian and 21 months in a hospital. And in every measure that we looked at within this project, we saw that children with life-limiting conditions are more intensive users of hospital resources. So they have more diagnoses recorded at discharge, they have more procedures recorded at discharge, they're in hospital for longer, and they're in intensive care for longer. When we think about technology, we looked at gastrostomy and tracheostomy tubes as markers of technology dependent. And the 6% of children when they're discharged have gastrostomies or tracheostomies, compared to 0.3% of the non-life-limiting children. And then we looked at complexity scores. I learned a lot. This is a mini tutorial on health economics. So when at the stage of discharge, HYPE codes are combined. The diagnostic related group is a way that health systems group patients into similar costs. And this is an idea of hospitals with increased complexity are refunded or reimbursed at a greater rate. So you have a major diagnostic group, then you have a marker of complexity, which is length of stay, whether you're in intensive care, etc. And then these are marked into levels of complexity, A being the highest resources. And you can see within this graph that when you think about children with life-limiting conditions who are admitted to hospitals as an emergency, 54% of those children at discharge are rated within the highest resource group, which is group A, compared to 12%, I think, of non-life-limiting children. So this is confirming that these children are more intensive users of hospital resources. So within Children's Health Ireland, this is not surprising data, but it's really important data for us to understand. We know that in a country the size of Ireland that we only have one major hospital group, or a hospital where they've got a lot of subspecialties. So there's things like oncology and cardiology which only happen within the CHI hospital group. And therefore there are higher rates of children with life-limiting conditions within those hospitals. But this is really important to consider. 17.3% of total inpatient discharges in CHI between 2009 and 2024 were children who had life-limiting conditions as a discharge, and this accounted for almost 40% of total bed days across the CHI hospital group. And intensive care units, which again, I just want to say one thing I want to say about the CHI piece is that the numbers start to drop off between 16 and 19, but there are children within the age group of 16 to 19 who are still being recorded within the CHI group. So not all children are being transitioned at 16, and that's an important thing for us to consider as we think about next stages in research. We think about intensive care units, so the only intensive care units that we have for children under 16 in Ireland are based within Temple Street and Crumlin. And again, this demonstrates most children, when they're admitted to hospital, have no contact with intensive care, which is the good news. But if children with non-life-limiting conditions are admitted into intensive care unit, their stays in intensive care units are short, typically less than 3 nights. Only 1.1% of children with non-life-limiting conditions are in ICU for more than 11 days, compared to over 4% of children with life limitations who, when they're admitted into hospital or into intensive care, stay there for long periods of time. So their mean length of stay in intensive care unit is 11 days. And again, if you've any had experience of caring for or experience of having loved ones in an intensive care unit, it's a really, not from a resource-intense perspective, but from a patient experience, family experience, being in intensive care is really, I think, challenging on all levels, clinically, psychosocially, emotionally, everything. Right. And this is a really nice, inspired admittedly by Lorna Fraser's Welsh group, but this is a really nice infographic just demonstrating to us that this is a small cohort of children who are really intense users of hospital services, and that we'll start looking at those prolonged admissions into hospital, prolonged admissions into intensive care units, they are overrepresented. So what does this mean? We now have data which tells us what those of us who work within this area already believed or understood. And these are really important considerations for policymakers. And people have spoken about this before, but I think it's really important to think that the reason we're here, the reason we go to work every day, the reason why we did this research was to think about the child and the family behind the statistics. And Orla's already spoken about this so importantly, about the importance of thinking about the child and the family and the impact and how we can make that. It will always be traumatic to be in intensive care unit, but there's things that we can do to make that easier. So in-hospital supports for parents and carers, understanding that parents need to be able to focus when they're in an outpatient department, when they're listening to doctors within clinics or on the wards, and providing support or care for their child while the parents are listening. That we need more space for these children and their equipment, and I'm really happy I've been in the New Children's Hospital, and I think the one thing that's really going to make a difference within the New Children's Hospital and existing hospitals is the space within the hospital rooms, the built-in accommodation for parents in every single bedroom, and the access to a bathroom for every every parent. So you will be able to have a shower, because you will literally have to just step 3 seconds away from your child's bed. If you had a baby, you could push the cot into the bathroom with you. Thinking about supporting children being able to bring things from home. Again, one of the things we have in the new hospital is the What Matters to Me boards in every room, which humanizes or makes the child and their personality and their family more visible. So supporting children bring things from home, their favorite pillow, their favorite duvet, their favorite teddy bears. Lots of parents do that already. The parents who know their way around the system do that already, but we should be supporting, encouraging and advising parents to do things like this. And then we think about the parents who are travelling from Limerick and West Cork and Kerry and Donegal, thinking about the development of more child-friendly transport services. And for us as policymakers and providers, are recognising the complex care needs across our children's services. What we've demonstrated in this is that within every children's hospital and every ward under every team in this country, there are children with life-limiting conditions. So it is not good enough that there is a small cohort of healthcare professionals who understand palliative care. And we need to have child-centred, family-focused, holistic care across all of our services. All healthcare professionals need to be educated in the palliative care approach to understand about meeting the holistic needs, so not just the clinical needs, but the psychological needs, the educational needs, the need to play, the need for fun, the need for family time for all of our children. We need all healthcare professionals to be able to identify, assess for and identify palliative care needs and refer to palliative care services when appropriate. And there's been loads of work. We recognise that the Irish Hospice Foundation work within the hospice-friendly hospitals, and the education that's come out of the BWE report are steps in the right way. And Samantha's going to talk about this, but think we need to examine the reasons behind lengthy hospital stays. For some children, it is necessary for those children to be in hospital for prolonged periods of time, but there are many children who are in hospital for long periods where there are non-medical, non-clinical reasons for prolonged hospitalizations which need to be examined and addressed. And people are going some way towards that, but I think there's further steps to go. And day cases, Orla will tell us, and all the families will tell us, that it's easier to be able to come up to the hospital, get everything done and go home. It's easier to sleep in your own bed than it is to sleep in a hospital room. So there is some room to examine whether we can consolidate appointments and treatments within day cases rather than prolonged hospital admissions.